Good evening. This is Sharon Fitzpatrick. I'm your host for tonight's webinar. We're going to focus on men's health, sex, ED, and your prostate. So we have a really full agenda for tonight. So we have Dr. Edward Cartman and Nurse Barb is going to be our main moderator. So just a reminder that we have some handouts in your dashboard. So you'll be able to download a copy of tonight's presentations and even a little bit of page where you can have some notes as well as a couple of other things that we're going to be talking about tonight. So without further ado, let me turn this over to Barb.
Thanks so much, Sharon, and thank you all for joining us tonight. I'm Nurse Barb Dean. I'm a women's health nurse practitioner here in the heart of Silicon Valley, and I see patients who obtain their care at El Camino Hospital. Tonight, I can tell you I am delighted to welcome Dr. Edward Cartman to our webinar series. The focus on men's health, sex, erectile dysfunction, and your prostate. Let me tell you a little bit about Dr. Cartman because he's very impressive. He is the medical director of the men's health program here at El Camino Hospital. He is a board-certified urologist, and he's one of very few urologists who are fellowship trained in male reproductive medicine and surgery, microsurgery, and male sexual dysfunction. Dr. Cartman is a graduate of the University of California, Davis, and he completed his medical degree at the University of Vermont, where he scored in the top 5% of all medical graduates in the nation. So he's a smarty pants. Dr. Cartman is not only very well-spoken, he's an award-winning researcher, surgeon, as well as a highly sought-after speaker on all aspects of men's health. He's appeared on NBC, Fox Radio, NPR, many podcasts, and I'm thrilled that you've agreed to speak with us tonight. So welcome, Dr. Cartman.
Thank you, Nurse Barb. Thank you for having me.
Oh, it's great to have you here. I know we're going to talk about a lot of important things and a lot of things that are important to a lot of people. So before we get started, here's a few details about tonight's webinar. If you haven't already downloaded the International Prostate Symptom Score, and you can find a link for that in the chat box, please do so. There's a link in the control panel, and this will help you determine if there are any concerns about your prostate health. Also, El Camino Hospital has a really cool new thing. It's called a manual. Get it? M-A-N, like manual. The emphasis is on man, and this is a guide to men's health, and it's geared to what's important to men. I mean, let's be honest, right, Dr. Cartman? Men are willing to put up with a lot of aches and pains and other issues, and they like to wait and see how things are going to work out before they get care. And, you know, I get it. I see women. Men and women are very different, but men need a different approach, don't they, to healthcare?
Absolutely. And the other thing I'll say is that men care about their sexual function and their prostates more than they care about their hearts.
Oh, well, that kind of makes sense, right? Because you can see your penis, right? It's there all the time. Yes. You can't really see your heart. You don't really know how it's functioning. But your penis, as we're going to find out later, is kind of a bellwether for your overall health, right?
Absolutely.
Cool. So stick around. We have so much to talk about. What I'm really excited about tonight is that as we talk about men's health, the program here at El Camino offers everything from primary care, orthopedics, heart health, digestive conditions, and sleep and sexuality issues. All of these issues are handled here at El Camino with sensitivity, expertise, and discretion. So tonight, be sure to take notes. We're going to have time at the end for questions. And if they come up as we're talking, please type them in the chat box, and we might be able to get to a few in the middle. At the end of this webinar, you'll be sent an email with an evaluation, plus links to all of our cool resources. Today's presentation was developed by a team of experts here at El Camino Hospital, including myself, but especially Dr. Cartman. So I'm so glad all of you are here with us tonight. So let's dive right in. Dr. Cartman, can you tell our audience what we're going to cover tonight?
Yeah, so we're going to talk about some of the most important things to a man and some of the most common problems that I see in my men's health practice on a daily basis. We're going to talk about urination issues, flow issues. We're going to talk about Prostate health. Men hear a lot about their prostates, whether to check their PSAs, what's happening to it, the importance of prostate cancer. That is the #1 cancer that men get as they get older. And we're going to talk about something that I really like to talk about, which is sexual health. And we're going to cover some of the treatment options, and we're going to talk about a very new, exciting treatment option that we've started doing here at El Camino, which has been shown to be very effective, safe, with virtually no side effects or complications.
Really? That sounds almost too good to be true.
It is the magic fairy dust that every patient wants me to sprinkle on them in order to fix their problem, yes.
Awesome. Well, we're going to hear about that a little bit later on. And we're going to do no spoilers. Before we go any further, I'd like to know a little bit more about who's listening in today. So we're going to do a poll to find out a little bit more about you. So, have you ever seen a provider for concerns about urination or your pelvic or sexual health? So, yes, no, or you prefer not to say. And Sharon's going to run this poll for us.
We've launched the poll, and just a reminder that some of the things that Barb talked about as having links, we've also got as handouts, so you can download them as well.
So what are you finding for the poll so far, Sharon?
Right now we've got about half the people have voted. Let's give it maybe another 15 seconds, and I'll close the poll and share the results. But right now, I would say we are 50-50.
Oh, 50-50. Okay, so do these results surprise you from our poll that some people have talked about their sexual concerns with a provider?
Well, it is surprising, and it's encouraging that we have 50% of people who have talked to their providers about this, because this is, especially when it comes to sexual health issues, men in particular are very hesitant to bring up the subject. And I call this the interpersonal dilemma, where guys will sit there in front of their doctor thinking, well, I hope he asks me if I have a problem. The doctor's stand there thinking, I hope he asks me if he wants to talk about it. And nobody wants to talk about it. No one initiates the conversation.
So we know that these issues are very, very difficult to discuss from both sides, right? How do you help bridge that divide, Dr. Cartman? How do you help allay some of the hesitation and embarrassment your patients might be experiencing?
Well, when it comes to guys, and being a guy, I know a lot about this, I've realized that guys are better at locker room talk than with the really big words when it comes to sexual health issues. So we use words that I won't use on the air here, but I try to keep it simple and straightforward. Oftentimes people don't know the difference between an erection, an ejaculation, an orgasm, an emission. And so they come in complaining of one problem when they really have a different problem. So I try to break it down to the very simple terms that make it easier for them to understand, because there is a lot of confusion with the nomenclature, the words that we use in medicine. They're definitely not the words that a lot of people use in everyday life.
And I bet you normalize it, that a lot of men experience some of these issues, that you're not alone. And there's a lot of things that we can do to help you with some of your concerns.
Well, absolutely. And telling a guy that he's not the only guy that has erectile dysfunction, and he's not the only guy who has a crooked penis, or he's not the only guy who has difficulty urinating or who gets up at night to urinate, is very important for these guys to hear, because there's an embarrassment that comes with some of these issues. And when they know they're not alone and they see a waiting room full of guys that are waiting to see me, they realize that they're not alone.
Yeah, that's important. So this is some data from 500 men who were seeking care for something completely unrelated to erectile dysfunction. And when they were evaluated, about half had ED. Then they were asked why they were hesitant to discuss this with their urologist, and 74% said they were embarrassed. Do you find this with your patients?
Yeah, and I love this study, and I've quoted this study many times to patients and to practitioners, and it is the case, and there has to be an icebreaker, and I think it's the responsibility of the physician or the care provider to break the ice. Tell them, hey, what's going on? Ask the questions, be direct, and kind of unarm them, so to speak, so that they feel comfortable talking to you about it.
And we're going to talk a little bit more about this later, but also, not everyone has a urologist or a provider who's going to bring it up. Is there one key message you would give to patients to say, do talk about this with your provider, talk about your flow, talk about how often you're getting up at night?
Well, the key message is it could be a bigger problem that's under this simple problem. And we'll talk about this in the next couple slides. But things like erectile dysfunction are really systemic diseases, meaning they affect different parts of the body, not just a man's penis. And a man's low testosterone, for example, can be affecting his bone health. It could be associated with a sleeping disorder such as sleep apnea. And many guys are surprised to find out the association between these common problems that they're suffering with and more serious medical conditions that are more life-threatening.
Well, that's a perfect segue into talking about the flow, right? Some of the issues that men might start experiencing after a certain age. So can you explain what men might start to notice as they reach 40 and beyond with the flow of their urine stream?
Yeah, so when men get older, and I tell this to every one of my guys, is that the chances that you're going to have a prostate problem are as likely as the chances are that you're going to get wrinkles and gray hair. It's not a question of if, it's a question of when it's going to happen. So the things that guys will experience are a slowing of their flow, hesitancy to start their flow, and post-void dribbling, standing at the bathroom too long. The worst thing for a guy is when he goes to a sporting event or a concert, and guys understand what I'm talking about. We all line up at these troughs, and you have several men who have come and gone already, and you're still standing there waiting to finish peeing. And these are embarrassing situations for these guys. Frequent urination, urgency to pee, and the worst case when guys really come to see you is when they start leaking urine because they can't control it.
Oh, wow. No one wants to leak urine. That's not good for anyone. So a lot of times this is related to the prostate, and I know you showed me the International Prostate Symptom Score questionnaire. We just happen to have that for you. It's a download, and I want to show you. We have a little representation of it here on this slide, but I'd like to go over some of the questions now. So you can download it, you can fill it out, and you can see where you are. So here's what you're going to see on this. So we're going to go to the next slide so you can see some of the questions. As you fill out this form, Dr. Carmen, can you help us understand why is it so important that we find out if these conditions are happening not at all, a few times, or almost always?
Well, it's a good way to quantify for your doctor how severe this problem is, because the reality is that it's very difficult for a man who's never practiced urology or done any of the sophisticated tests that I do in my practice to really elaborate and explain how well or how poorly they're urinating. This is a great validated questionnaire, and I don't know if you guys noticed, but this was a coincidental finding, but it's called the IPIS, IPSS.
IPIS, I like that.
So that's what we call it in urology, but it's a validated questionnaire that helps us identify patients. So like most questionnaires, it's a screening questionnaire, so that when someone comes in while they're waiting to see us, they fill these out. So by the time they come to their chance comes up to talk to me, I can look at this real quickly and say, whoa, you're not urinating very well, or it doesn't look too bad to me.
Mm-hmm.
And it's a good starting point for our discussion and for further testing.
Mm-hmm. And what if a man says to you, well, for the most part, all of this is fine unless I've had coffee or I've had a few beers. Does that make any difference for somebody who might be hydrating a lot or drinking a lot of coffee?
What I find is a lot of guys are in denial, and what they're doing is they're looking for excuses to justify why they're doing these things. So remember, when you're 20 years old, you could drink all the coffee and beer that you want, and you don't have these problems. A lot of men will start compensating for these problems, and one of the things that I find is that, for example, we find hernias in a lot of men who have prostate problems. Why is that? Well, because these guys are straining so hard to pee that they actually cause themselves to develop hernias. We find guys develop kidney stones. Why do they get kidney stones? Well, they realize the less they drink, the less often they run to the bathroom, and that dehydration causes them to form kidney stones. So they develop these secondary problems because they don't want to accept the underlying problem, and they do all these compensatory things and say, well, it's the coffee's fault. Well, it's the beer's fault. Well, it's not the coffee's fault or the beer's fault. It's your prostate's fault, and you need to get it addressed.
All right, and we're gonna do another poll now. Let's talk about nighttime visits to the bathroom. We know that a lot of times men start to get up in the middle of the night, just like women do after a certain age, to visit the bathroom. So we'd like to find out from our audience how often you get up to go to the bathroom in the middle of the night. So never, you sleep through the night, 1 to 2 times, 3 to 4, 5 or more times. So as we get ready for this, Sharon, you're going to run the poll now.
I am. I'm just going to ask everybody to put in chat what your answers are, so we'll be able to share it with everyone.
That'd be great. So can you talk to us a little bit about how important this is for us to know, or for you to know, how many times people are getting up to go to the bathroom at night?
So the nocturia question, or getting up at night, was incorporated into that IPIS questionnaire because when people start getting up at night to pee, it's a later stage symptom of enlarging prostate. So what's happening is their bladders are becoming irritable such that they can't go for long periods of time without urinating, and that happens at night. And when it happens at night, it's more disruptive to their lifestyle. Let's face it, if you have to go run to the bathroom every hour or two during the day, you might be able to deal with it so long as you have a bathroom nearby. But when you have to wake up every hour or two in the middle of the night to urinate, you're going to be pretty tired in the morning, and you're going to be grumpy, and you're not going to be happy. One of the things I want to comment on, though, regarding getting up at night, we used to think of this as just a urologic problem. And in fact, when I was in my residency over 15 years ago, we rarely ever ordered, I don't think I ever ordered a sleep study. And this is a revelation that I think we've had in the last decade, the association between things like sleep disorders such as sleep apnea and getting up at night. And we used to treat guys with medicines, behavioral modification, water restriction, even surgeries. And some of these guys, we couldn't even get them better. And the one thing that we didn't do back then, because we didn't know, was how about doing a sleep study? So one of the big integral parts of our men's health program here at El Camino Hospital was to develop a sleep center for our patients so they could get high quality evaluations of how well or how poorly they sleep. And now we understand the association of sleep apnea and getting up at night. And sometimes guys come to me because they're getting up at night, but their real problem is sleep apnea.
That's great. I love the comprehensive approach that you take. So you're not just looking at one issue. You're looking at the whole system, the whole body, and how everything interrelates. So Sharon, what are we finding with this poll?
We're finding 40% say 3 to 4 times.
Wow.
Wow.
And the rest are pretty evenly split with the other answers.
Well, that's great that you're here tonight with us if you're getting up 3 to 4 times a night, because we're going to get a lot more information for you to help improve your life and your lifestyle. So let's talk a little bit about the scores for the IPIS, right? If a man adds up his scores, 0 to 7 is considered mild, 8 to 19 moderate, and 20 to 35 is severe. Why should someone see a provider ASAP, or as soon as possible, if they score so high on their IPIS?
So the reason is that this has been going on for a while, okay? And you don't go from 0 to 21 overnight. You don't go from 0 to 35 overnight. It's a problem that's developed probably over years, if not even over a decade, for these men, and they've really been neglecting this. And the real issue is once it gets that severe, you're really causing a lot of damage to the bladder. And one of the things I try to emphasize to my patients even though you might be tolerating getting up at night 3 to 4 times, you might be tolerating the slow stream, you're okay with being the first guy in, the last guy out of the public restroom, your bladder doesn't like it. And one of the worst things that I see in my practice when it comes to prostate enlargement and prostate symptoms is the guy that has neglected his bladder so much that when he comes to me finally for help, there's not much I can do for him because he's got bladder failure. And it's very analogous to what happens to everybody if they neglect their blood pressure. And this is why we're so aggressive at treating high blood pressure in our society, is that your heart is pumping against these stiff arteries, and over time, it's just going to give up. It's going to fail. And so the same thing happens to your bladder. When it has to squeeze urine through a tight, big prostate, it'll compensate, but over time, it's going to fail. And let me tell you, you think quality of life is bad now, wait till you have to live with a catheter for the rest of your life, or you have to catheterize yourself 4 to 5 times a day to empty your bladder. That is no good quality of life.
Wow. So this is really important information for people to get out there. And it's for not only those of you who are listening, but when you're talking to your friends, and I know a lot of times guys talk about this, they're like, yeah, it's been a little bit different, stream's a little different. Don't wait. So don't wait. This is not going to get better on its own.
Exactly. I think that's the best thing to tell a guy is don't wait, see a doctor about it.
Well, we've been talking a lot about the prostate, and now we've got a little picture of the prostate, where it is. And can you just talk to us a little bit about why do we have a prostate anyway? What good is it?
So, yeah, it's a great question. And if I ask the average person, what does the prostate do in the man's body, they would probably tell me it's there to cause misery in the man's life when he gets older. But in reality, the prostate is actually a reproductive organ, and it produces the fluid, most of the fluid, along with the seminal vesicles when a man ejaculates. So people think when a man ejaculates, that's all sperm. Actually, sperm only make up 5% of the total volume of a man's ejaculate, and the other 95% comes from this organ. And it's very important in a man's reproductive life, but once he's done having kids, it really is just there to cause problems. It enlarges, it can develop cancer. And as we're living longer and longer, prostate problems weren't really a problem 100 years ago when we all kind of died at the age of 40. Mm-hmm. But now that we're all living into our 80s and even 90s and even into the year 100, we're giving it a chance to develop enlargement and cancer.
Okay, well, speaking of cancer, there is this test called the PSA, right? The prostate surface antigen test. And when you do a prostate exam, we have a nice picture here of the digital exam, right? And a lot of men are not happy with this exam, but this is the best way to check. But there's also ultrasound and the PSA. What do you recommend for the age that someone should start getting a PSA, or is there no real guidelines here?
Well, the guidelines are constantly shifting. So a few years ago, this group of government people got together. By the way, none of them were urologists, but they looked at the literature and they came up with a consensus that we should stop screening for prostate cancer with the PSA. And then there was a reverse in the direction several years later. Once the urologists got involved and we started talking to the United States Preventive Task Force. And now the current guidelines are such that any man under the age of 40 should not get screened. Men between the ages of 40 and 55 should only get screened if they have, if they're African American, if they have a strong family history of prostate cancer with a first degree relative. And then men over 55 to, they say, 69, 70 should get screening after discussing it with their doctors. And men over 70 should only get screened if they have a life expectancy greater than 10 years. So I'm very hesitant to tell any one of my 71 or 72-year-olds, I'm giving up on you because I think you're going to die in less than 10 years. So that's a discussion that is difficult to have, and it's an easy test to do. I think the the decision point shouldn't be whether we check a PSA or not, because it's an easy test to do. It's cheap. The decision point shouldn't be really whether we do a biopsy or not. The decision point should be after you've had your PSA, and if you need a biopsy, you get a biopsy. And then if you have cancer, the decision point should be right there. Does this cancer need treatment, and what kind of treatment, if any, does this cancer need? And that's where I think the message has been lost by the media, is that they keep focusing on just throw the baby out with the bathwater here, forget about PSA, it doesn't need to be checked. And I think, and a lot of urologists think this way, is that the PSA is still a valuable test. And I always tell my guys that, well, if we don't check your PSA, what's the alternative? There is no alternative. There is no other good test, screening test for prostate cancer. So essentially you're saying to yourself, I'm going to just roll the dice, I'm going to stick my head in the sand, and if I get the most common cancer that men get as they get older, then I'll deal with it.
So I like what you're saying. It's, if you're concerned, go ahead and get tested. Don't hesitate to be tested. And we talked earlier about how it's kind of inevitable. As people age, it's inevitable that the prostate's going to enlarge, and after men stop having their children, what good is the prostate? So I want to show you something here, but you can see a normal prostate and then an enlarged prostate. But it's called benign prostatic hyperplasia, BPH. So it can be benign. It doesn't necessarily mean it's cancerous, right?
Right. So benign refers to the medical terminology, cancerous or benign, and it doesn't mean that it doesn't affect any part of your life. It's not benign in the sense that it's irrelevant.
And you and I were talking about this is almost inevitable. So most men will have some prostate enlargement.
Yeah, as you can see from this graph, I tell guys it's an almost linear increase with a decade of life, starting at the age of 40, and it's not exactly linear. It accelerates quickly there in our 50s and 60s for men. But yeah, a lot of men get this, and in fact, surgeries for BPH are the second most common surgical procedure we do in the entire field of medicine, only surpassed by cataract surgery.
Really? Really? So this is so common, and it's treatable.
Yep.
So this is treatable. A man doesn't just have to live with an enlarged prostate?
Yep.
Really?
The problem is that so many men confuse BPH treatments with prostate cancer treatments, and they all hear about men who've had their prostates removed for cancer and might develop impotence, erectile dysfunction, or incontinence where they leak urine, and so they're very scared to have anything done on their prostate. And it's a very common question that I get from my patients, especially when I bring up the subject, the need for surgery, is their concern for impotence and incontinence. And I'm not saying it never happens, but the incidence of developing any problem with your erectile function after a BPH surgery is extremely low.
Okay, that's reassuring. And we're going to get to some of the treatments, but I want to find out if our audience has any concerns about their prostate. Let's see if people are joining us because they have a concern. So you see here we have a poll, and Sharon, I'll let you take over.
Yeah, so what we'd like you to do is to just put your answer in chat, or if you feel one of these is yours, just raise your hand and we'll count you that way. So just let us know.
Do you have a concern about your prostate? Yeah, you've been told it's enlarged. Yes, you have an elevated PSA. Yes, but do you have more questions? No, I think I'm good, or I'd rather not say. But people can live with BPH, but they don't have to, because you're telling me that we have some treatment options that are not going to cause impotence, and they're not going to cause leaking of urine or incontinence. So what are we finding from our audience, Sharon?
About 2/3 of our audience has raised their hand for yes.
Oh, wow. That they do have a concern about their prostate. Okay, Dr. Karpman, you guys have come to the right place. What do you think about this 2/3? Is that about right?
That's about right.
Okay. So since BPH is common, it sounds like it should be evaluated. And more serious consequences, you talked about damage to the bladder, but are there other consequences?
Yeah, well, in the old days, before we had effective treatments for BPH, actually, it used to be one of the most common causes of kidney failure. So as the prostate becomes more obstructive, the urine backs up all the way to the kidneys, and it could actually damage the kidneys. It can cause infections. It can cause stones to form in the bladder. I don't know if you ever saw pictures, old westerns or movies where you see the old guys, if they've made it to the old age, we used to walk around with like walking sticks and canes.
Oh, yeah.
So one of the things they used to do is they used to have little twist-off ornaments, like metal pieces, and they would have little catheters in their canes. So in the old days, before we had medications and surgeries, guys would pull out their little catheter, which obviously was not sterile, it was dirty, would have to catheterize themselves, and then they put it back in their cane. And needless to say, those guys would all ultimately develop infections, and a lot of them would die of these infections because we didn't have good antibiotics to treat them. But that's if you leave BPH alone and don't treat it, that's what's going to happen to you.
Holy moly. I know there's a couple of internet stars who talk about self-cathing all the time, and they're self-cathing because their prostates are so enlarged. Maybe. Right. So let's talk about some treatments. And I know we can just observe, right? There's medications for the prostate, but also there's a lot of minimally invasive procedures. And minimally invasive means that, again, we're talking about no impotence and no incontinence or no leaking. Can you just briefly tell us about some of these minimally invasive treatment options?
Yeah, so again, since this is such a common problem, there's a lot of industry involvement. Everyone wants to try to develop some kind of new treatment for this. So we have office-based procedures, such as a treatment called Resume, which is a steam therapy for the prostate, where we can do it in our office. It takes about 15 minutes to perform. And guys can get some pretty good results. There's a thing called UroLift, where these sutures or staples that we put in the prostate, we can do those in the office. We have a variety of different types of lasers, which are extremely effective. We are actually here at Camino. We're one of the first hospitals to acquire the newest technology, or the sexiest technology for treatment of BPH, which is called aquablation. So a lot of treatments historically for BPH have relied on heat therapies. So you heat the prostate up, and it either shrinks over time, or the heat is so high that it actually can carve out or vaporize the tissue, making the opening wider. But very few treatments, or if any, have ever used cool therapies. So aquablation it's actually a company that was started here in the Bay Area. It's called Prostate. And what they do is they use pressurized water. So they could pressurize water through a little channel up to about 10,000 psi, such that it can actually remove the tissue, and it's very effective. It is also guided by a robot and an ultrasound. So an ultrasound is used to kind of map out the prostate. The surgeon then draws on the screen the contour of the prostate. You place a device into the prostate, you hit start, and the device does all the work for you. And this is a great evolution in the field of BPH surgeries, because it essentially now is standardized every patient's surgery to the same outcome, and which is a good outcome. So most surgeries are very surgeon dependent, so that's why people look for a great surgeon who has a lot of experience doing this procedure, that procedure. And aquablation is essentially taking that out of the equation, and it's standardized such that no matter if you come to a urologist at El Camino Hospital, or to a urologist somewhere in Texas or New York or Pennsylvania, you're going to get the same results, because it's the technology and not the technician that's doing all the work.
Wow, that is really encouraging. And a lot of these procedures, how long does it take for a man to get back to his life after maybe one of these procedures?
Pretty quickly. So most guys walk out of the hospital or the office after these procedures. Now, the holy grail of any prostate operation is still to do it without a catheter.
Mhm.
And I'm going to concede that catheters are not fun, and that's a good. I think it's a good reminder to most guys why they should get their prostate treated, because we'll tolerate a catheter for a day or two,
Mhm.
but we definitely won't tolerate a catheter for the rest of our lives. And so the catheter is a temporary thing for a couple days, and guys can usually get back to their full activities within a couple of weeks.
Full activities meaning sex.
Yeah, sex within 2 to 4 weeks.
Wow. Well, that's encouraging. So again, I'm thinking don't hesitate if you're starting to have any of these issues, or you do the International Prostate Symptom Score or the IPIS, and you're finding that you're in the red or the yellow zone. Don't wait. It's time to get this evaluated. And when we were talking about getting back to sexuality, it's a perfect segue for us to switch gears now and talk about one of your favorite topics, one of my favorite topics, and that's sexuality. So before we dive into that, we're going to launch another poll, because so often I find with women, they don't bring up sexual concerns. They're really waiting for me to do it. And thank God that I've been taught how to talk about sexual concerns with patients. I know you have as well. So let's ask our audience, have you ever seen a provider for concerns about urination or your pelvic or sexual health? So we have yes, no, or prefer not to say. And as we're waiting, Dr. Carmen, how did you become more comfortable talking about sex with your patients?
Well, it was a necessary task in order to break the ice with guys. And like I said, I think bringing it down to a average person's level and not talking to people, down to people from a medical level is important, because like I said, a lot of people don't know these terms that we use on a daily basis, or our meetings, or in our journals, to describe all these different aspects of it. And I think explaining it to patients in a simple way, in regular English they can understand, helps them open up. And kind of like I said, locker room talk. That's the easiest way, for at least in my experience, to get a guy to open up about sex. Because let me tell you, as a guy, amongst guys behind closed doors in the locker room, we do talk about sex in our own way.
As you should, because your sexual health is an important part of your overall health.
Absolutely, and it's very important for. I guess we're going to talk about this soon, but we're going to talk about the associated problems that when a man has a sexual problem, which are even more important than the sexual problem itself.
So Sharon, what are we finding with our poll?
Well, let me share the results. We've got 67% say yes, and 33% say no. And before we go on, we've had a couple of people who are trying to check to see if they have a handouts tab. So I just want to remind people that if you go up to the top of your dashboard, you'll see view, and you can pull down that menu, and handouts tab should be checked. If it's not, you can check there. If not, let us know. We will send it to you offline. And I'm going to close the poll, hide it, and go back to you.
All right, so I'm glad that people are talking about their sexual and pelvic health concerns. And now let's talk about the Masters and Johnson graph here that you guys are going to see. This is and I changed the word typical male sexual response. It used to say normal, but there's so many variations of what a normal sexual response is. But this is according to Masters and Johnson. Dr. Carmen, can you walk us through this?
Yeah, sure. And I love this graph because, I practice here in Silicon Valley. I'm surrounded by engineers. Engineers love data. They love to graph everything. And this is what sex would look like if you put it on a graph. In the y-axis, you have your level of excitement, and on the x-axis, you have the period of time. And the excitement phase is a short period of time where we get a sharp rise in level of excitement. The plateau phase is the majority of the sexual response cycle, and we have a small increase in excitement. And then there's the orgasm, which is another burst, a sharp burst of excitement over a short period of time. And finally, there's the resolution phase, and I jokingly say that's where guys roll over and fall asleep.
Yes, I think a lot of people can relate to this. And where does erectile dysfunction come into this graph? Where do we find erectile dysfunction issues?
They'll be in the plateau phase,
And
because that's where we need a sustained good erection. So erection that is strong enough for penetration. And one of the things that I think people oftentimes don't understand about erectile dysfunction, it's not just getting an erection, it's keeping an erection long enough to reach orgasm or climax.
Mm-hmm.
So a lot of men think just because they can get it hard, even if you get it hard 100%, but it doesn't stay hard long enough for you to reach climax, they think they're okay, they don't have a problem.
Mm-hmm. And we're talking about not only penetrative intercourse with a partner, but we're also talking about masturbation and when men are self-stimulating or self-sexual. So erectile dysfunction can happen with or without a partner. Is that correct?
Correct. It doesn't have to be with a partner. It's just the ability to obtain and maintain an erection adequate for sex throughout the process.
Okay, well, how common is erectile dysfunction? We call it ED. Is this something that a lot of people have?
Yes, it's actually another very common problem. And what you're looking at here is the pie graph is from the Massachusetts Male Aging Study. And this is one of those population studies where they follow a large group of people in this one population, and they bombard them with various questionnaires from everything from cardiovascular disease to pulmonary health to erectile dysfunction. And in this group, mind you, this is only for men between the age of 40 and 70, and the assumption is that men over 70 don't have sex, which is not true.
That's not true.
Exactly. So this is just limited to 40 to 70, and if we included men 40 till the end of life, these numbers would be a lot more severe. But you could see 40 to 70, about 52% of men have erectile dysfunction, and most of the time the problem is truly physical and it's not in their head.
That's reassuring. I think so many times people think that it's in their head, but it's a physical issue 9 out of 10 times. And so we don't really need to be ashamed about this, right? This is something, if it's physical, maybe we can help with that.
Absolutely. And, I jokingly tell people sometimes that, they used to think it's in a guy's head because a guy just thought about sex too much. And if he'd stop thinking about sex so often, he wouldn't have a problem. And it's not the case. So guys don't think about sex all the time, well, at least not all guys. And so when we do identify men with erectile dysfunction, like you said, the vast majority of the time, it is a true organic problem.
And as you guys can see from here, 40% of the time it's vascular, and 30% of the time it's diabetes, but there's a lot of other issues. We're going to talk a little bit more about about a man's vascular health, and we're going to show you some illustrations that show the vascular, the system inside the penis, the arteries, the capillaries, and why your vascular health, and that means your cardiovascular health, right? The vessels that pump blood to and from your heart, why that's so important for your penis. So when men have erectile dysfunction, should they start by seeing their primary care provider, or should they just go see a urologist right away? What is your advice?
They should go see a doctor, and I think any doctor can evaluate them for the comorbid conditions, so long as they understand the comorbid conditions. And it's still surprising that a lot of people don't understand the association between erectile dysfunction and cardiovascular disease. And erectile dysfunction has become the new symptom for cardiovascular disease. And nowadays, it would be analogous that if a guy showed up to with erectile dysfunction, it'd be analogous if he showed up also and said, "Oh, and also I have chest pain, a pain radiating to my jaw down my left arm," and I said, "Oh, here's some Viagra. Go ahead and use that. Don't bother getting checked out." I think when a man comes in complaining of erectile dysfunction, it's important to get a good, thorough cardiovascular evaluation. Sometimes guys are taken aback. They're like, "I'm in good health. I don't need this." And I'll tell you, I've diagnosed men with severe, life-threatening cardiovascular disease that have come to see me for erectile dysfunction. I've had guys who come to see me just for their erections, and we find that they have occluded arteries requiring stents to be placed, having heart bypass surgeries. And these men are incredibly grateful to me for helping them understand that erectile dysfunction is not just a standalone disease anymore. And it's never been a standalone disease. It's just our understanding of it has always been that it's a standalone disease. And I think we've saved these guys' lives, because if they didn't come in to see us, they would have gone along with their lives, and one of these days they'd be playing golf and all of a sudden they'd have a big heart attack.
Mm-hmm. Wow. I love how comprehensive the care is. And what we see here is that men's sexual function is dependent upon well-functioning blood vessels. But these blood vessels in the penis and in man's reproductive organs are kind of a good snapshot of what's going on in other parts of a man's body.
Absolutely. And when guys develop this condition, we call it atherosclerosis. And a lot of people have heard that term before, and essentially it's hardening of the arteries or blockage of the arteries. And when that happens, it happens diffusely in all of your arteries, not just in your heart. So if a man if he has atherosclerosis in his penis, then there's a high probability that he also has atherosclerosis in his heart arteries, his brain arteries, and that means he's susceptible to a heart attack if it's in his heart, or to a stroke if it's in his brain.
Wow, so can we go backwards, Sharon? So we just saw a picture with atherosclerosis, which shows blockage in the arteries. But in this picture, in this illustration here, you see the vascularity of the penis. There's a lot of blood that needs to pump through here very quickly. Tell us more about this. How do you explain this to men?
Well, so an erection is nothing more than blood filling up into these chambers that we call the corpora cavernosa, and you have two of those chambers. And you need an adequate blood supply in order to develop enough pressure to get a fully rigid erection. And if you have a bottleneck in there because you have narrowing of those arteries because of atherosclerosis, you can't generate enough pressure in order to get a full erection. And that's what guys start experiencing, versus the 90% rigid erection and the 80% rigid erection. It slowly starts to dwindle. And surprisingly, guys are really hesitant to come see you until it drops below some critical threshold.
So we've been talking so much, and I want to get to those really cool treatments. So we're going to skip over this Tampere study that I love, which basically, I'm just going to give you a synopsis. I talked to Dr. Cartman about it earlier. It's basically use it or lose it. And then we have oral therapies that I think a lot of people are familiar with for erectile dysfunction. And what I'd like to do is spend a little bit of time on the latest and the greatest new treatments that many people have not heard about. But Dr. Cartman, I'd like you to talk to us about this low-intensity shockwave therapy for erectile dysfunction.
I'm really excited about this. This is one of the big advances in the field of sexual medicine. When Viagra came out in 1999, it really revolutionized the field of sexual medicine because we finally had a great oral drug. And since that time, we've just had other types of drugs that have been coming out to the market, which are very similar. But all those drugs have side effects. They need to be taken on an empty stomach. You can't take alcohol with them. And I always tell guys, starving and sober is not the way I like to have sex. Right, Barb?
Right.
So we like to wine and dine them first and then do it. So there's limitations to those drugs. And I hear this all the time from my patients that, that they just don't work for me. So, and one of the trends that we're seeing in medicine now is trying to capitalize on our body's own ability to heal itself, to regenerate itself. And this would go in that category of regenerative medicine. And what we learned many years ago is, and this was from the cardiovascular surgeons in Germany, that they were using low-intensity shock waves for men who had blockages in their heart to develop new blood vessels around those blockages when they couldn't do surgery. And then in 2010, somebody said, hey, where can we where could we use more blood vessels, more blood flow? And this group of guys from Israel said, hey, let's check it out if it works in the penis. So they published the first study in 2010 using low intensity shock waves, and sure enough, it showed a significant percentage of men had improved erections after undergoing a few office-based therapies. And the way this works is essentially we all have stem cells in all parts of our body, and the question is, how do we stimulate them to work? So when you cut yourself, you traumatize yourself, you automatically activate those stem cells. Well, we're obviously not going to cut the penis, all right? But these shock waves are enough energy to give a shear stress to these stem cells that live in a man's penis, which then start releasing growth factors, which cause new blood vessels to form, improving the blood flow of a man's penis.
Wow. So does this hurt?
Not at all. And I was actually surprised by this. When we started doing this, the manufacturer told me, even though it's effective, you could even put it on a man's testes and it won't hurt. I didn't believe that. I said, no way. The testes are so sensitive. You cannot do shockwaves on a man's testes. And I had a patient who was willing to let me put this on his testes, and he said it didn't hurt.
Oh, cool. And we're going to jump now to penile implants. These are penile prosthetic choices. We see a 1-piece, 2-piece, and 3-piece. I'd like to talk about the 3-piece inflatable penile implant. Could you tell us more about this? Because it looks like a lot for men. And when you first told me about this, I think a lot of men have the same reaction I did. Wait a minute, you're going to make an incision in my penis, but you say you don't need to touch the penis to do this.
No. Well, let me just first say that the most shocking thing that to most guys when I bring this up is that this exists, and they ask how long has this been around. Penile implants have been around for about 47 years. This is not something new. They've been around for a long time. And the surgery has been modified so much such that nowadays, at least in my hands, we can do this through an incision that's about 1 inch. It's a 1-inch incision above the penis, not on the penis. We can do this surgery under 30 minutes.
Wow.
Minimally invasively, and we can get guys back to full sexual function in 3 weeks after the surgery.
Wow, 3 weeks. We don't have to cut you don't have to cut the penis. And do people like this? Well, first of all, tell us how it works. How do you do this?
So the most common type of implant is the 3-piece implant. I call it the Cadillac of penile prostheses, because it's the one that really gives a man a very physiologic erection. And I'll tell you that I have guys, I put these in that are dating, they haven't told their new partners about this, and they don't know that it's in there. They don't know that anything's going on. The best is I did one of these in an 82-year-old guy, and he dates younger women. And the women always ask him, how is it at your age you have such a strong erection? And he always lies to them and says it's all natural. So it's very natural. It's very physiologic. There's water in the system. So if, heaven forbid, something should go wrong and there would be a leak, there's no detriment to the patient. The water will be absorbed by your tissues and you'll pee it out. The water's in the reservoir. It's a closed system. And essentially when a man wants to have an erection, he reaches between his testes, where we put a pump, and he pumps water into the cylinders, which are in his penis, and he pumps it up to his desired firmness. And if most guys go to 100% firmness on that, the penis is harder than their natural erection was when they were 20. Most guys usually stop at about 85-90%, so it feels more natural.
Oh, wow. This is exciting. I think it's very hopeful for people. And as you were telling me, most people who have this would recommend it to others. So 92% of men would recommend it, and 90% of their partners would also recommend this.
So that's from a published study, and I would say that in my practice, I think those numbers are even higher. And one of the best things, I love getting the thank you card from the female partner of the guy that I put in a penile implant in,
Mm-hmm.
and hearing about how this has changed their lives, how this has brought intimacy back into their relationship. It's just amazing how something as simple and not very much talked about in medicine, such as a man's erection, can have such a big impact on a man's overall outlook on life. And let me tell you, once you give them one of these great penises, they want their bodies to match. So oftentimes I'll see these guys, they start saying, well, now I got to get in shape, I got to lose weight, I want to match my penis now.
I want to match my penis. Wow. I want to get to some questions. We've covered a lot of information tonight. Dr. Cartman, you're amazing. I think we should do this again.
I think so too.
Okay. So I want to thank everyone for joining. I know you have a lot of questions, but before then, I want to just remind you, do download the manual. Do check out El Camino's Men's Health Program, where we provide sensitive care. And we have experts in all aspects of men's health. And as Dr. Cartman said, your sexual health can often be a bellwether of the rest of your health, especially your cardiovascular health. You could go to our website for more information. We even have a Find a Doctor link, South Asian Heart Center, Chinese Health Initiative. So now let's just jump into the questions. And Sharon, you're going to read them to us, right?
Yes. So we do have a question that says, the penis and everything that happens, is it related to a culture or a heritage, whether it be East Asian?
So what do you think, sometimes with erectile dysfunction, do you think that there's cultural or religious things that might impact what a man is experiencing?
Well, I'd have to know the specifics of, everyone's culture. But again, the thing is that if you lead a healthy lifestyle and you watch your weight, you control your blood pressure, you exercise, these are problems that are very much avoidable. But if in your culture you are eating unhealthy foods, I know in the South Asian culture, that's why I think we developed this South Asian Heart Center here at El Camino Hospitals, because there are very unique aspects to lifestyle there that do impact earlier onset of heart disease,
right,
which can then translate into more incidents of erectile dysfunction.
Yeah, and South Asians also have a higher risk of having Lp(a), which is a very highly atherogenic lipoprotein that can lead to earlier heart attack. So if you have a strong family history of that, do go see your healthcare provider, and the South Asian Health Center might be a good place to start. We have another question.
We sure do. Does BPH often cause erectile dysfunction?
No, it doesn't. They're really not associated, although that some of the treatments for BPH overlap with the treatments for erectile dysfunction. So one of the ED drugs, Cialis, is actually used to treat both conditions. In fact, the company came out with a low daily dosing, so that men, specifically designed for BPH, that men can take it on an everyday basis to treat their prostate symptoms. And of course, the beneficial side effect is that it also helps their erectile function. But the two are very much separate disease states, and they're both, though, related to similar receptors. There are things called alpha receptors in the prostate as well as in the blood vessels to the penis. And so when you block an alpha, or you do an alpha blocker, it relaxes the prostate, but it also relaxes the blood vessels in the penis.
Oh, that's good to know. So an alpha blocker, a lot of men take alpha or beta blockers for hypertension, and so sometimes medications can cause some erectile dysfunction. Do you ever talk to a person's cardiologist and say, can we modify their blood pressure medication, or do you work on it in a different way?
Whenever possible, yes. If we can get the cardiologist to modify their medications, that's the ideal thing. But we always say, life over limb, and in this case, the limb is the penis. So we're never going to compromise a man's cardiovascular health to improve his erection. And so if there is a problem and he needs to stay on those medications, we need to work around it.
That's good. We have one more question.
And this will be our final question for tonight. With an enlarged prostate, PSA4, and a clear MRI, should I pursue a biopsy?
That's a great question. It's one of those judgment calls. So you have a PSA of 4, which puts you right at the cusp of being abnormal. That's the threshold. A prostate MRI, I want to let everyone know, is not a definitive study. It's sexy. It's new. It is high-powered, but it is not 100% conclusive. And so the gold standard is still always to do a biopsy. I think a prostate MRI is one of those things that helps kind of change the odds in one direction or the other, but ultimately a biopsy is the only true way to determine whether a man has cancer. And our best indicator to recommend a biopsy would be an elevated PSA.
So it sounds like this person should speak further with their own healthcare provider about their own unique situation.
Yeah.
Okay, well, we are out of time. I want to thank everyone, and especially you, Dr. Carmen. It's been a pleasure, and I've learned so much. Thank you.
Thanks for having me, Nurse Barb.
All right, and we will be posting these links on the El Camino website, also on my website, nursebarb.com. And again, we want to thank you for joining us, and please do fill out your evaluation because it helps us design other webinars for the future. All right, take care.